1, 2,
And review, somebody female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's, charter book.
300 please.
I'll keep you on again.
Pulse check. No pulse.
No more pulse.
Yeah. Here, what do the ECMO people say? And her blood pressure is off the properly.
45 minutes of CPR and no return of circulation. Okay.
Oh. Oh.
You know, when you think about a hospital setting, and specifically about medical diagnoses in general, there's usually this like underlying expectation of precision.
Right, yeah, like everything is black and white.
Exactly.
Yeah.
It's almost like structural engineering. Like if you fall and break your arm, you go to the ER, the tech takes an x-ray, and there's that undeniable, jagged white line across the bone, and the doctor just points at the screen and says, there's the fracture, and you cast it. It's entirely objective.
It is, yeah. It's incredibly binary. I mean, it's broken or it's not broken. It's a clean, categorizable problem. And from a clinical standpoint, that's deeply comforting. We like things to be visible. We like them to fit neatly into boxes.
Right. We love the boxes. But then you take the elevator up to the maternity floor, you step into the world of obstetrics, neurodevelopment, and postpartum care, and suddenly that metaphorical x-ray machine is, well, it's completely useless.
Oh, completely. You're flying blind in a way.
Yeah. You're looking at a clinical landscape that is, quite honestly, incredibly murky. I mean, first of all, you're dealing with two patients simultaneously.
The postpartum client and the newborn?
Exactly. And the warning signs for both of those patients are rarely as obvious as a jagged white line on a screen. Sometimes the most dangerous red flags are just like subtle behavioral shifts in the mother.
Yes.
Or maybe it's a slight drop in a baby's temperature that looks entirely harmless to the untrained eye, but is actually setting off a catastrophic physiological chain reaction.
It's the absolute definition of diagnostic muddy waters. And for a nursing student or a newly minted nurse stepping onto the maternity floor for the very first time, those muddy waters are exactly what makes obstetric nursing so daunting.
Terrifying, honestly.
Right, but it's also what makes it so highly testable. Because in obstetrics, you aren't just treating a disease. You're managing a massive dynamic physiological transition. The margin for error is razor thin, and the exam boards know that.
Which is exactly why today's deep dive is designed the way it is. We are looking at a massive stack of clinical nursing sources, comprehensive modules focused on postpartum and newborn care, discharge teaching, and clinical adaptations.
But we aren't just going to read you a syllabus.
No. Absolutely not. If you're listening to this, you are likely staring down the barrel of a major OB nursing exam, or you're prepping to walk into your clinical rotations. And you need to know how to think like a safe, highly competent future nurse. So we're shifting into full study coach mode today.
That is precisely the mission. My goal here today is to act as your elite clinical mentor. We're going to apply the Pareto principle aggressively to these source materials.
I love that, the 80-20 rule.
Exactly. That means we aren't going to try to memorize every single floating fact in these textbooks. We are going to sift through the weeds, bypass the fluff, and isolate that core 20% of high-yield concepts that will deliver 80% of your exam value.
Right, the stuff that actually matters.
Yes. We're going to focus heavily on clinical judgment. I want to teach you how to prioritize, how to spot the exam traps that instructors just love to set, and most importantly, how to differentiate between a finding that is expected and a finding that requires your immediate clinical intervention.
Okay, let's unpack this. I am absolutely ready for this, and let's dive right into the deep end. We have to start with the postpartum client's psychological state. Because practically speaking, if I walk into a patient's room to teach them about newborn safety, but they're like mentally overwhelmed or completely checked out.
Everything you say is just noise.
Right. It's just Charlie Brown teacher noises.
It is a phenomenal place to start because you see this exact scenario play out all the time in clinical practice. A nurse walks into a postpartum room armed with this massive checklist of discharge teaching. They need to teach the client how to swaddle, how to mix formula safely, how to care for the umbilical cord stump, and the nurse just starts talking. But the patient is, staring out the window, completely glazed over, just rhythmically rubbing their own abdomen, not absorbing a single word.
Yeah, the information just bounces right off them.
Yeah.
So why does that happen? Because looking at the literature, there's a very specific framework for this, right? Riva Rubin stages of maternal role attainment.
Yes. Let's make this our first high-yield core concept. Instructors love testing Rubin stages because this framework directly dictates both when and how you provide patient education.
Oh, interesting. So it's about timing.
Exactly. If you teach at the wrong time, you have failed as a nurse because the patient goes home unequipped. Rubin identified 3 distinct psychological phases a client goes through after giving birth.
Okay, let's break those down physiologically and psychologically. Stage 1 is called the taking in phase. According to the source material, this occurs in the first 24 to 48 hours after birth. And the focus here is almost entirely on the client themselves, right? Like they're focused on meeting their own basic physiological needs, sleep, food, pain relief. And they spend a lot of time reflecting on the birthing experience itself.
The taking in phase is absolutely crucial to understand. And to understand why it happens, you have to look at what the body just went through. The client has just survived a massive physiological and psychological marathon.
Right.
They've lost blood, their fluid volumes are shifting drastically, their endocrine system is undergoing an earthquake, and they are basically running on the fumes of an adrenaline crash.
So when they want to talk endlessly about the labor, like who was in the room, how much it hurt, what the doctor said, is that just them being, I don't know, self-centered? Because I can imagine a new nurse getting frustrated that the mother isn't immediately focused on the baby.
It is not self-centered at all. It's a vital psychological integration process. Think of it like a soldier coming back from a highly intense, chaotic deployment or an elite athlete right after the Olympic finals.
Oh, like reviewing the game tape.
Exactly. They have to process the trauma, the shock, and the triumph of the event. They are literally taking in the reality of what just happened to their physical body. They need someone to validate that experience.
Okay, so clinically, how does an exam test this? If I get a question where a client is 12 hours postpartum and she just keeps repeating the story of her emergency C-section over and over, what's the trap?
The trap is the impulse to redirect. The multiple choice options will try to trick you into saying something like, redirect the client to focus on newborn feeding schedules.
So you don't do that.
That is the wrong answer. During the taking in phase, your priority nursing action is to actively listen, provide comfort measures, and allow them to process. Do not overload a patient with complex newborn discharge teaching during this window.
Because they just can't absorb it yet.
Right. They simply do not have the cognitive bandwidth to retain it. You focus on their pain, their food, their sleep, and their emotional validation.
So when does the switch flip? When do they actually start caring about the fact that they have to, keep this tiny human alive?
That brings us to stage 2, which is the taking hold phase. This usually begins around day 2 or day 3 postpartum, and it can last for several weeks.
Okay.
At this point, the physical shock has somewhat subsided, and the client's focus shifts outward to the newborn.
And the sources say this is when they want to learn, but they're also dealing with a lot of anxiety about their own competency. Like, am I doing this right?
Exactly. They want to take charge, they want to change the diaper, they want to manage the feeding, but they're terrified of doing it wrong. This is your golden window for clinical teaching.
Oh.
When the exam asks for the optimal time to initiate independent newborn care education, you are looking for the taking hold phase. This is when you utilize the teach-back method.
So you demonstrate the swaddle, and then you have them take hold of the blanket and show you how to do it.
You got it. They are ready to assume the role.
And just to complete the framework, the final stage is letting go, right?
Correct. Stage 3, letting go, is a much longer process that takes months. This is the profound psychological integration of their former pre-pregnancy identity with their new identity as a parent.
Like grieving their old life alone.
Yes, exactly. They have to mourn and let go of the idealized fantasy of what they thought birth would be like or what they thought their baby would be like and accept the reality in front of them. It's when they might go back to work or redefine their romantic relationship with their partner.
Got it.
But for the immediate hospital setting that you will be tested on, your main job is distinguishing carefully between a mother who is taking in and a mother who is taking hold.
That makes perfect sense.
Yeah.
We are matching our interventions to their cognitive readiness. But staying on this topic of the maternal mindset, the sources flag a massive high-stakes area for exams regarding perinatal mental health.
Yes.
Specifically, we have to know how to distinguish between the expected baby blues and the highly dangerous postpartum depression.
Yes. Highlight this section in your mind right now. The timeline and the severity of symptoms here are the absolute keys to answering these exam questions correctly.
Okay.
Instructors will give you a detailed clinical scenario with a crying, overwhelmed mother, and you have to know if it's an expected physiological response or if it's a psychiatric red flag.
Let's start with the physiology of the expected finding, the baby blues. The sources state that the baby blues are triggered by an abrupt, massive decrease in hormones, specifically estradiol and progesterone, the very moment the placenta separates from the uterine wall.
I want you to visualize the placenta for a moment. For 9 months, the placenta has been acting as a massive endocrine factory,
Right.
pumping out staggering amounts of estrogen and progesterone to maintain the pregnancy. The moment that placenta is delivered, that factory shuts down instantly. It is a hormonal cliff dive.
Wow.
The drop in these hormones drastically alters neurotransmitter pathways in the brain, specifically affecting serotonin and dopamine.
So it's essentially a biologically induced withdrawal state, like cold turkey.
That is a brilliant way to conceptualize it. It's an acute withdrawal. Because of that, experiencing emotional lability, meaning sudden mood swings, is incredibly common. Up to 80% of postpartum clients will experience weepiness, anxiety, feeling overwhelmed, and irritability.
But the clinical trap is the timeline, right?
Yeah.
How long is this allowed to last before we start worrying?
The defining characteristic of the baby blues is that they are transient. They peak around day 4 or 5, and they resolve entirely within the first 2 weeks after birth.
Okay, 2 weeks is the cutoff.
So if you get an exam question where a client is 8 days postpartum, she cries easily when a commercial comes on television, but she's still actively feeding the baby, showering and sleeping when the baby sleeps. That is an expected finding.
So your nursing action is simply to offer emotional support and reassurance that this is normal.
Exactly.
Okay, but what happens if we're at week 3 or week 4 and she's still crying? Or, like, what if the symptoms are much darker than just being weepy?
That is when we cross the clinical threshold into concerning territory. Postpartum depression, or PPD. Postpartum depression typically manifests over the first 2 to 3 months postpartum, though it can start anytime in the first year.
How does the presentation of PPD differ from the baby blues in a test question? Like, what are the buzzwords?
It's about the depth of the darkness and the loss of function. This isn't just crying at a sad movie. This is a pervasive, heavy, depressed mood. You will see anhedonia, which is the severe loss of interest in activities they used to enjoy.
Okay.
You'll see feelings of intense, paralyzing guilt or feelings of complete incompetence as a parent. You'll see severe sleep disturbances. And this is a key exam clue right here. The baby is sleeping soundly, but the mother has severe insomnia and cannot sleep at all.
Oh, that's a huge red flag.
It is. And most critically, you may see suicidal ideation or thoughts of harming the infant.
Looking at the priority nursing actions for PPD, the sources are incredibly rigid. It says universal screening is a priority, using valid tools like the EPDS, which is the Edinburgh Postnatal Depression Scale, or the PHQ-9.
Yes.
And you have to screen every single client. No exceptions.
Universal screening is the gold standard of care. You do not just screen the patients who, quote-unquote, look depressed.
Because anyone can hide.
Exactly. You screen the affluent mother, the mother on her 4th child, the surrogate mother who just delivered for another family. You screen everyone because postpartum depression does not discriminate, and patients are often exceptionally good at hiding it out of shame.
What if a patient does screen positive? Or, like, what if during your assessment she makes an offhand comment about feeling hopeless or wishing she wouldn't wake up?
That is a drop everything moment. If a client expresses any feelings of hopelessness or overwhelming despair, your absolute priority nursing action is to directly, explicitly assess for suicidal thoughts or plans.
You mean you literally ask, are you thinking of killing yourself? Because I think a lot of new nurses are afraid that asking that question will somehow, I don't know, put the idea in the patient's head.
That is a very common fear, but all psychiatric evidence shows that's a total myth. Asking directly does not cause suicidal ideation. It actually provides relief to a patient who is drowning in those thoughts.
Wow, okay.
You do not dance around it. You say, are you having any thoughts of harming yourself or your baby? You must assess if they have a plan and if they have the means to carry out that plan. Maternal and fetal safety is always, without exception, your first priority.
That is incredibly clear. Okay, so we've secured the psychological baseline. We understand how to approach their learning readiness based on Rubin's stages, and we know exactly how to draw the line between the baby blues and postpartum depression. But a mother cannot safely care for a newborn, no matter how psychologically ready she is, if she's, internally hemorrhaging or developing a systemic infection. So Let's pivot the clinical lens to maternal physical recovery.
This is where we move from psychology to pure pathophysiology. In the immediate postpartum period, your job as a nurse is to act as a sentinel. We need to clearly separate the expected, messy, uncomfortable realities of giving birth from the life-threatening red flags that require immediate medical intervention.
Let's start with the most obvious physical finding: the bleeding. The clinical term is lochia. The sources say postpartum bleeding can last up to 6 weeks, and it should progressively get lighter in color and in volume.
Let's look at the why it matters here. Why is she bleeding in the first place? When the placenta detaches from the uterine wall, it leaves behind a massive open wound bed inside the uterus. It is literally the size of a dinner plate.
A dinner plate. That is terrifying.
It really is. The uterus has to violently contract, we call these after pains, to clamp down on those exposed blood vessels to stop the bleeding.
So the uterus acts like its own tourniquet.
Precisely. The muscle fibers of the uterus crisscross like a lattice. When they contract, they squeeze the blood vessels shut like living ligatures. As that wound heals over the next 6 weeks, it sheds tissue and blood.
And there's a specific progression of color, right?
Yes. That expected trajectory goes from lochia rubra, which is dark red for the first few days, to lochia serosa, which is a pinkish brown, and finally to lochia alba, which is a yellowish white discharge.
But the exam isn't just going to ask me what color lochia alba is. It's going to ask me to identify when that bleeding has crossed the line into a postpartum hemorrhage.
Exactly. And the priority red flag you need to sear into your brain is the pad saturation rule. Heavy bleeding is clinically defined as soaking a perineal pad in 1 hour or less.
Let me make sure I have that exactly right. Soaking one entire pad front to back in less than 60 minutes.
Yes. Write that down. If a patient calls you into the room and says, I just changed my pad 45 minutes ago and the new one is completely soaked through, or if she stands up and passes blood clots larger than a golf ball, that is not expected lochia. That is an emergency.
Because the tourniquet failed.
Exactly. It means the uterus has lost its tone, a condition called uterine atony, and those blood vessels are just pouring blood into the uterine cavity.
What is the very first thing I do in that scenario? I mean, I don't just log into the computer and chart heavy bleeding, right?
Absolutely not. You do not leave the room and you do not reach for the computer. Your immediate priority action is to physically intervene. You must perform a fundal massage.
How does that work?
You place one hand right above the pubic bone to support the lower uterine segment, and with your other hand, you aggressively massage the top of the uterus, the fundus, until it firms up. You are mechanically forcing that muscle to contract and clamp down on the bleeding.
Okay, so bleeding is obviously a massive priority. But looking at the cardiovascular system, the sources highlight a different kind of red flag. They explicitly call out a headache that doesn't resolve with medication, extreme swelling of the hands and face, and visual changes like seeing spots or floaters.
This is a phenomenal area for exam questions because it tests your ability to connect seemingly disjointed symptoms into a single terrifying diagnosis. What does that triad of symptoms point to?
Preeclampsia. But wait, I thought preeclampsia was a complication of pregnancy. Like, once the baby and the placenta are delivered, shouldn't it go away?
That is the exact misconception that kills patients, and it is exactly what instructors will test you on. Preeclampsia does not magically disappear the second the umbilical cord is cut.
Really?
Really. The underlying cause of preeclampsia is severe systemic endothelial damage to the lining of the blood vessels caused by factors released by the placenta. It takes time for the body to clear those toxins and heal the blood vessels.
Wow, okay.
Postpartum preeclampsia is incredibly dangerous because it often peaks 48 hours to a week after delivery when the patient is already sitting at home on their couch.
Okay, so physically, what is causing those specific symptoms? Why the headache and the floaters?
It is all about vasospasm and fluid leaking. The blood vessels are spasming, restricting blood flow. A relentless, severe headache that doesn't respond to ibuprofen combined with facial edema because fluid is leaking out of the damaged vessels into the tissues, and visual scotomas, those little floaters or spots in the vision.
What are the visual spots actually from? Is there fluid in the eye?
No, the visual spots indicate severe central nervous system irritability. The blood vessels in the brain and the optic nerve are spasming, causing localized ischemia or lack of oxygen.
Yes.
When the brain gets that irritable, the patient is at extremely high risk for a generalized tonic-clonic seizure, which we call eclampsia.
Oh, wow. So the floaters are basically the optic nerve screaming for oxygen right before a seizure hits.
Exactly. So if a patient reports these symptoms during a discharge teaching session Or if they call the postpartum triage line from home complaining of a severe headache and swollen hands, your priority action is to have them evaluated immediately.
So they come right back to the hospital.
Yes. They need their blood pressure checked, their urine checked for protein, and they will likely need intravenous magnesium sulfate to depress that central nervous system and prevent a seizure.
That is terrifying, but it makes so much sense when you understand the mechanics. Now let's look at another systemic red flag, fever. The cutoff given here is a temperature greater than 38 degrees Celsius or 100.4 degrees Fahrenheit.
Yes, 100.4 Fahrenheit is your clinical threshold for a postpartum infection. Now, it's very normal for a woman to have a low-grade temperature of around 100.0 in the first 24 hours, purely from the massive exertion of labor and the fluid shifts.
Right, running a marathon.
Right. But if it hits 100.4 or higher, especially after the first 24 hours, you have an infection until proven otherwise.
What kind of infections are we hunting for?
The most common is endometritis, which is an infection of that massive internal wound bed we talked about inside the uterus. But you also have to assess for wound infections from a cesarean incision or an infection of a perineal tear.
Which brings us perfectly to the hygiene and perineal care guidelines in the sources. The discharge teaching here is very specific to prevent those exact infections. Wash hands before and after using the toilet. Use a peri bottle, a squirt bottle with warm water, to rinse the perineum instead of wiping with dry paper. And use only peri pads. Absolutely never tampons.
The no tampons rule is absolute. In fact, the broader rule is never introduce anything into the vagina for at least 6 weeks or until explicitly cleared by a provider at the postpartum checkup. That includes tampons, menstrual cups, douches, and intercourse.
Why 6 weeks specifically? Is that just an arbitrary timeline?
Not at all. It takes roughly 6 weeks for the cervix to fully close and for that placental wound site inside the uterus to fully heal. If the cervix is still slightly dilated, the pathway from the outside world directly into the sterile uterine cavity is wide open.
Oh, I see.
If you introduce a tampon, you are pushing bacteria right up to the doorstep of a massive healing internal wound. It is a catastrophic infection risk.
That paints a very clear, very cautionary picture. Okay. Let's look at a topic that the sources highlight as a major source of confusion for clients, which translates into it being a prime exam trap, breast care. Specifically, we need to differentiate the care for a client who is lactating versus a client who is not lactating.
This is a classic compare and contrast scenario that nursing boards just love. You have 2 patients in the hallway complaining of severe breast engorgement and pain. One patient is breastfeeding her infant, the other patient is formula feeding and wants to dry up her milk.
Right.
If you give the wrong advice, you will actively make the patient's pain worse.
Let's tackle the lactating client first.
Yeah, for the lactating client, the sources recommend using moisture barriers like purified lanolin on the nipples, applying cool gel pads after feeding, and expressing a few drops of breast milk to let it air dry on sore nipples.
That is correct. For the lactating client, the clinical goal is twofold. Establish and maintain an adequate milk supply while healing the microtrauma on the nipple tissue caused by the infant's latch.
And the breast milk itself helps heal it. Yes, expressing a few drops of hind milk and letting it air dry is a highly effective evidence-based intervention because breast milk is packed with live macrophages and has incredible antibacterial and healing properties.
But for the non-lactating client, the rules completely flip upside down. The sources explicitly state, avoid stimulating the nipples, do not pump, do not express milk just to relieve the pressure, and do not let warm water run over the breasts in the shower.
I cannot emphasize this enough. The absolute exam rule for the non-lactating client is avoid all stimulation. To understand why, you have to understand the endocrine feedback loop.
Okay.
Milk production is a strict supply and demand system driven by 2 hormones, prolactin, which produces the milk, and oxytocin, which causes the milk to let down or release.
So if a mother's breasts are rock hard and painfully engorged, and she thinks, I'll just pump for 5 minutes just to take the edge off and relieve the pressure.
If she does that, the mechanical stimulation of the pump sends a signal directly to her anterior pituitary gland saying, the baby is hungry, send more milk. She might relieve the pressure for an hour, but her body will respond by producing even more milk, prolonging her pain for days.
What about this shower rule?
Yeah.
How does a mother take a shower without getting her chest wet?
She has to literally turn her back to the water. If warm water cascades over the breasts, the heat causes vasodilation and triggers the release of oxytocin from the posterior pituitary.
And that causes the letdown.
Exactly. That oxytocin causes the milk ducts to contract. It stimulates the whole system. She must keep her chest out of the direct stream of warm water.
So if she can't pump and she can't use warmth, what can the non-lactating client do for the excruciating pain of engorgement?
We use the principles of vasoconstriction and mechanical suppression. She needs to wear a well-fitting, highly supportive sports bra continuously, 24 hours a day, 7 days a week, to physically compress the tissue.
Just blind it up.
Yes. She should use ice packs inside the bra. The cold constricts the blood vessels, reducing blood flow and therefore reducing the swelling and milk production. And she can take mild analgesics like ibuprofen for the inflammatory pain.
Which serves as the perfect transition into the pharmacological interventions discussed in the sources. The modules break down a few specific medications you will be administering constantly on the postpartum unit. Let's start with the one you just mentioned, ibuprofen.
Ah, yes.
It's an NSAID, a non-steroidal anti-inflammatory drug, used heavily for after pains and perineal soreness.
Ibuprofen is the absolute workhorse of the maternity floor. We talked earlier about those violent uterine contractions, the after pains that stop the bleeding. Those contractions are driven by prostaglandins.
Okay.
Because ibuprofen inhibits the synthesis of prostaglandins, it is remarkably effective at dulling the cramping of the shrinking uterus, as well as reducing the inflammatory pain of a swollen, stitched-up perineum.
But, as with everything in nursing, the exam isn't going to ask you what ibuprofen does. It's going to ask you what dangerous side effects you need to watch out for.
Always.
The adverse effects listed here are intense. Visual changes, shortness of breath, bloody or tory stools, vomit that looks like coffee grounds, and little to no urine production.
Let's translate those textbook symptoms into clinical concepts. Let's start with the GI symptoms. Why would a patient have tarry stools or vomit that looks like wet coffee grounds?
Well, tarry stools usually mean old blood, right, so an upper gastrointestinal bleed.
Exactly. Prostaglandins cause pain in the uterus, but in the stomach, prostaglandins are responsible for maintaining the protective mucosal lining. When you give an NSAI and block all prostaglandins, you strip away that protective lining in the stomach, leaving it vulnerable to its own acid.
Oh, that makes sense.
This can cause severe gastric ulcers and internal bleeding. That digested blood looks like coffee grounds when vomited, or turns black and tarry in the stool.
That makes the mechanism so clear. Prostaglandins are the alarm system, but they're also the stomach shield. What about the kidneys? The sources mention little to no urine production.
That indicates acute renal toxicity. Prostaglandins also keep the afferent arterioles in the kidneys dilated, ensuring good blood flow to the renal system. When you block them with high continuous doses of NSAIDs, those blood vessels constrict, kidney perfusion drops, and urine output plummets.
So they just stop making urine.
Basically, yes. You must teach the client to monitor for these signs. Also, ensure they know not to double up on medications at home because many over-the-counter cold and sinus medications contain hidden NSAIDs and they can easily overdose.
That is a phenomenal breakdown. The next class of medications we need to cover are for a much less glamorous but equally painful problem. Patient Helen. The sources set up another great side-by-side comparison here, docusate versus Cesarean.
Constipation is a massive issue postpartum due to lingering progesterone relaxing the smooth muscle of the bowel, dehydration, and honestly, the sheer terror of pushing a bowel movement past a newly stitched perineal tear.
Understandably.
But instructors love pharmacology questions that test if you know the mechanism of action of the drug, not just the brand name.
Okay, looking at the pharmacology, there's a hard line drawn between these two. The text says docusate is a stool softener. It acts as a surfactant, allowing water and lipids to penetrate the stool mass, making it softer and easier to pass. But Cesarean is a stimulant laxative. It chemically stimulates the nerve endings in the large intestine to violently induce peristalsis.
Right. Let's use a construction analogy. Think of docusate as a hose bringing water into a concrete mixer so the cement doesn't dry and harden into a boulder. It just keeps things soft. Think of Cesarean as a mechanical press squeezing the concrete chute to aggressively force the material out.
Wow, okay. So if my patient just had a severe 4th-degree perineal tear that goes all the way to her rectum, my instinct is to give her whatever clears her bowels the fastest so she doesn't have to strain. But the literature screams no to prolonged use or using harsh stimulants unnecessarily. Why?
Because of the risk of dependency and mechanical trauma. If we connect this to the bigger picture, you can see how preventing constipation protects a newly repaired perineal tear. Keeping the stool soft with docusate prevents the client from bearing down and ripping those intricate sutures.
But don't use it forever.
Right, you should not use docusate for more than 1 week because the bowel can become dependent on it, losing its natural tone.
And what about Passacadil? Are there strict contraindications we need to watch out for?
Absolutely. Passacadil is a powerful stimulant. It is entirely contraindicated in cases of suspected bowel obstruction or appendicitis.
Why? Just an engineering issue. Like, if the pipe is blocked, you shouldn't increase the pressure.
Exactly. If the bowel is physically blocked by an impaction and you administer a medication that violently stimulates peristalsis against that immovable blockage, the pressure builds up and you can literally cause a bowel perforation.
Oh, that sounds awful.
The intestine ruptures, spilling fecal matter into the abdominal cavity, causing massive sepsis. So you must always assess bowel sounds and the presence of pain before giving a stimulant laxative.
Wow. Okay, so we have fully stabilized the mother.
Yeah.
We know how to navigate her psychological phases. We know how to spot the physiological red flags of hemorrhage and preeclampsia, and we understand the mechanics of her medications. But now she has a tiny, wet, highly vulnerable alien to keep alive. The transition from the warm, fluid-filled womb to the cold, dry outside world requires massive physiological adaptation for the newborn. Let's shift our clinical focus entirely to newborn vulnerability, specifically zeroing in on thermoregulation.
This is arguably one of the most critical safety topics in all of neonatal care. In utero, the baby does not have to expend a single ounce of energy to stay warm. The mother's core body temperature does all the work for them.
Sure.
But the absolute second they are born, they are wet, they are exposed to a 70-degree delivery room, and they suddenly have to regulate their own temperature. And physically, they are terribly unequipped to do it.
Let's talk about why they're so unequipped. The modules point out that newborns have a very high surface area to volume ratio. Like, they have giant heads and tiny bodies, which means their heat escapes rapidly into the environment.
Yes.
And crucially, they cannot shiver to generate heat like adults do. Instead, the text says they rely entirely on metabolizing something called brown fat.
Yes, the clinical term is non-shivering thermogenesis. Because their muscles aren't developed enough to shiver, they rely on brown adipose tissue or brown fat. This is a specialized, highly vascular tissue that is packed with mitochondria.
Where is it?
It's located in very specific areas, between their shoulder blades, around the back of the neck, and surrounding vital organs like the kidneys and the heart.
How does brown fat actually work? Does it just act as, like, insulation?
It is not just a blanket. It is an active furnace. When temperature receptors in the baby's skin sense cold, their sympathetic nervous system fires, releasing norepinephrine. This triggers the mitochondria in the brown fat to essentially short-circuit their normal energy production and instead burn fat purely to generate localized heat.
Which then warms the blood flowing past it.
Exactly, thereby warming the baby's core.
But the text emphatically highlights a concept called the danger of cold stress. It says that as the infant tries to compensate for the cold, they increase their metabolic rate and their oxygen consumption skyrockets. Why is that so dangerous?
This is the exact pathophysiological cascade you need to master for your exams because it explains the why behind almost everything we do for a newborn. Burning brown fat is an incredibly metabolically expensive process. It is not free.
What does it cost?
To stoke that furnace, the newborn's body requires massive continuous amounts of oxygen and glucose.
Okay, so if the baby stays cold, what happens? Let's walk through the domino effect.
If the cold stress is prolonged, the first domino to fall is glucose. The baby will rapidly burn through their stored glycogen reserves in the liver, leading to profound hypoglycemia. A hypoglycemic baby becomes lethargic and too weak to eat.
And the second domino?
Oxygen. Because they are using so much oxygen to metabolize the fat, they are stealing oxygen away from their brain and vital organs, developing hypoxia.
Right.
Hypoxia causes the pulmonary blood vessels to constrict, worsening the oxygenation. And finally, the byproduct of burning all this fat without enough oxygen produces lactic acid, leading to the final domino, metabolic acidosis.
So if you let a baby get cold, you don't just have a chilly infant. You have rapidly created a hypoxic, hypoglycemic, acidotic baby.
Exactly. It is a lethal triad. That is why thermoregulation is not just a comfort measure. It is a critical, life-saving clinical priority.
To protect them from that triad, we have to know exactly how they lose heat into the environment. The sources detail 4 specific physical mechanisms of heat loss. And I know from talking to nursing students that these 4 terms get mixed up constantly on multiple choice questions.
They absolutely do. Let's create a foolproof clinical memory anchor for each one so you never get them confused again. The 4 methods are evaporation, conduction, convection, and radiation.
Let's start with evaporation. The physics here is a liquid turning into a gas. The exam clue provided in the text is failing to dry the baby immediately after birth or after a bath.
Evaporation is the single most significant cause of heat loss in the first few minutes of life. Think about stepping out of a swimming pool on a breezy day.
You freeze instantly.
Right. The baby comes out of the birth canal completely coated in warm amniotic fluid. If you do not aggressively and immediately dry them off with warm towels, that moisture evaporates into the dry room air, pulling massive amounts of the baby's core body heat away with it as it turns to vapor.
Next is conduction. This relies on direct physical contact. The text gives the example of placing a baby directly on a cold metal scale.
Conduction requires two solid surfaces touching each other. Physics dictates that heat always transfers from the warmer object to the colder object.
So the baby warms up the scale.
Yes. If you take a warm 98-degree baby and put them bare-skinned onto a cold metal scale, a cold stethoscope, or cold hospital sheets, the baby's heat transfers directly into that cold object until their temperatures equalize.
So what's the nursing intervention there?
It is entirely preventative. You put a warm blanket or a paper barrier on the scale before you place the baby down, and you warm your stethoscope in your hands before you touch their chest.
Number 3 is convection, the flow of air. The exam clue here is a cool air conditioning draft blowing across the crib.
Convection is about moving air currents sweeping heat away from the body. Think of a convection oven, which uses a fan to circulate hot air to cook food faster. If the baby's open bassinet is parked right under an air conditioning vent, or if there is heavy foot traffic rushing rapidly past the crib, the moving air constantly steals the layer of warm air right next to the baby's skin. The intervention is to keep the ambient room temperature warm, keep the baby wrapped, or place them in a specialized incubator called an isolette if needed.
And the final method is radiation. Proximity without contact. The example given in the text is placing the crib near a cold, drafty window. Wait, let me make sure I understand this mechanically. Are you saying a baby can get dangerously cold even if the ambient room air is perfectly warm, just by being positioned near a cold window?
Like thermal radiation?
Yes, and that is exactly the counterintuitive scenario instructors use to trick you on an exam. Radiation is the transfer of heat between solid surfaces that are not in direct physical contact.
How does that even work?
Have you ever stood a few feet away from a single pane glass window in the middle of winter? The air inside the room might be set to 72 degrees, but you feel a chill radiating off the glass.
Oh, yeah. Actually, what is happening is that your body heat is radiating outward toward that cold glass. The exact same thing happens to the baby. If their crib is placed near a cold outside wall or poorly insulated window, they will invisibly bleed heat to that cold surface via thermal radiation.
That is fascinating. So to recap our memory anchors, evaporation is wetness, conduction is touching, convection is moving air or drafts, and radiation is proximity to cold surfaces. So if we look at the priority nursing actions for overall thermal regulation, what are the biggest takeaways?
Dry the infant aggressively and immediately after birth. Discard the wet towels right away so they aren't lying on cold, damp linen that covers evaporation and conduction.
Right.
Place them skin to skin directly on the mother's bare chest and cover them with a warm blanket. The mother acts as a massive, living, radiant warmer. Put a knit hat on their head because they lose a staggering amount of heat from the large surface area of their scalp. And finally, delay the first bath.
Okay, we have successfully stopped them from freezing. We've protected their brown fat. But because of the energy they expended during the birth process, they still need to replenish their glucose. They need to be fed, and then they need to be put to sleep safely.
Absolutely.
This transitions us perfectly into infant nutrition and safe sleep. The modules state these are the two tasks parents will be doing almost exclusively at home, making them massive targets for discharge teaching questions on the NCLEX.
Let's tackle feeding first. Specifically, we need to look at breast milk storage guidelines. If there's one thing nursing board instructors love more than testing pathophysiology, it is testing a chart with exact, memorizable numbers.
The CDC guidelines provided in the sources are very explicit. Freshly expressed or pumped milk can sit out at room temperature for up to 4 hours. It can go in the refrigerator for up to 4 days. And if it goes into the freezer, it is best used within 6 months, though it's technically acceptable up to 12 months.
The memory anchor here is the rule of 4s and 6s. 4 hours on the counter, 4 days in the fridge, 6 months in the freezer. But let's look at the why it matters.
Okay.
Why are these rules so strict compared to, say, a can of powdered formula? Because breast milk is essentially a living biological fluid. It is packed with live macrophages, antibodies, active enzymes, and very rich milk sugars.
It's basically a highly nutritious soup.
Exactly. And bacteria love that soup. If you leave it sitting at room temperature for too long, any ambient bacteria or bacteria from the pump parts will multiply exponentially, turning that milk into a dangerous pathogen vector for a newborn with an immature immune system.
There's also a very specific rule in here about leftovers. It says if a baby drinks from a bottle but doesn't finish it, you have to throw out the unfinished milk within 2 hours of the baby finishing the feeding.
Yes.
Why a strict 2-hour cutoff? I mean, if it's just in the fridge, why can't it just put the half-empty bottle back in the fridge for tomorrow? Breast milk is liquid gold. Parents hate throwing it away.
It breaks every mother's heart to pour breast milk down the drain, but the science dictates it. The moment the baby's mouth touches the bottle nipple, a backwash of saliva enters the bottle.
Ah, the saliva.
Yes. The infant introduces the natural bacteria from their mouth directly into the milk. That bacteria immediately starts feasting on the rich lactose sugars in the milk. If you put that contaminated bottle back in the fridge and try to feed it to them 6 hours later, you are no longer feeding them milk. You are feeding them a massive, incubated bacterial colony.
Oh, that's gross.
It will cause severe gastrointestinal distress. Discard after 2 hours, period.
Okay, another major anxiety for parents.
Yeah.
How do they know if the baby is actually getting enough milk? They're breastfeeding. They can't see the ounces disappearing from a bottle.
You measure the output. What goes in must come out. The expected objective clinical finding is that by the time the baby is 5 days old, they should be producing at least 5 to 6 heavy, wet diapers daily. That is your undeniable objective data that hydration and intake are adequate.
What about hunger cues? How do parents know when to start feeding? The text calls out a major exam trap here regarding crying.
Yes. This is a huge teaching point. Crying is a late sign of hunger. It is a sign of desperation.
So if you wait until the baby is screaming their head off to feed them, what happens?
They are going to be neurologically disorganized, frantic, and panicked. They will flail. They won't latch well onto the breast. They will swallow huge amounts of air, which causes gas pain, and the feeding will be a complete disaster.
So look for early cues.
You must teach parents to recognize the early, subtle feeding cues. Rooting, which is the reflex where they turn their head to the side with an open mouth, seeking the nipple, lip smacking, tongue thrusting, and bringing their hands to their mouth. The clinical mantra is, you feed when they are rooting, not when they are raging.
That makes perfect sense from a behavioral standpoint. Now let's talk about the other half of the newborn's existence, sleep. The modules heavily emphasize safe sleep practices to prevent SEID, which stands for Sudden Unexpected Infant Death.
The clinical rules for safe sleep are absolute and non-negotiable. Instructors test this relentlessly because adherence to these rules saves lives.
Tell me the rules.
Always place the baby flat on their back for sleep. Use a firm, flat, tightly fitted surface, meaning a certified crib or bassinet mattress. No soft objects, no pillows, absolutely no stuffed animals, no bumper pads around the rails, and no loose blankets.
The sources also specifically highlight room sharing versus bed sharing. It says room sharing is highly recommended for at least the first 6 months, but bed sharing is expressly not recommended. Mechanically, why does room sharing help?
Room sharing decreases the risk of SUIs significantly. When the baby is in a bassinet next to the parent's bed, the ambient noises of the parents shifting, breathing, and moving actually help keep the baby from falling into a sleep state that is too deep. That slight external stimulation is neurologically protective.
But if they're right next to you, why is it so dangerous to just bring them into the adult bed?
Adult mattresses are soft, they create indentations, and they are covered in heavy duvets and pillows. Bed sharing is incredibly dangerous due to the risks of positional asphyxiation, entrapment between the mattress and the wall, and overheating from the radiant heat of the adult bodies.
And you could just roll over.
Exactly. An exhausted parent can easily roll over an infant. The risk is simply too high.
The text also mentions offering a pacifier at sleep times. I know some parents hesitate to use them, but why does the medical community recommend a pacifier to help prevent SUID?
There are 2 physiological reasons. First, the mechanical act of non-nutritive sucking physically helps keep the baby's airway open by pulling the tongue forward, preventing it from obstructing the pharynx.
That makes sense.
Second, sucking alters their neurological arousal thresholds, making it easier for their brain to wake them up if they experience an apneic event, which is a temporary pause in breathing.
What about swaddling? The text says swaddling resembles the tight secureness of the womb, keeps them warm, and helps decrease the Moro reflex, which is that startle reflex where they throw their arms out and wake themselves up. But it has very clear safety limitations.
Swaddling is a fantastic evidence-based tool for the first few months, but you must know the clinical cutoff point. You must instruct parents to stop swaddling the absolute moment the baby shows any signs of attempting to roll over independently. This usually occurs around 3 to 4 months of age, but sometimes earlier.
Because if they manage to roll onto their stomach while their arms are pinned tight in a swaddle,
They cannot use their arms to push their chest up, and they cannot turn their heavy head to clear their airway from the mattress. The suffocation risk skyrockets instantly.
the text also talks about the physical mechanics of how the swaddle is wrapped.
Yes, the anatomy of the swaddle is critical. It must be snug across the chest to suppress the startle reflex, but it must be loose around the hips and legs.
Why loose around the hips? Doesn't the womb keep their legs scrunched tight?
It does, but in a flexed position. The baby's legs must be able to naturally fall outward into a flexed frog-like position.
Okay.
If you take a blanket and wrap their legs tightly straight down, forcing the legs together like a burrito, you exert mechanical leverage on the hip joint. You can literally force the cartilaginous head of the femur right out of the hip socket, causing permanent developmental hip dysplasia.
Loose hips, snug chest, stop when they start rolling over.
Got it.
Okay. We are moving into our final major topic. Highly testable newborn procedures. We've covered the daily routines like feeding and sleeping, but these are the specific clinical tasks and procedures that nurses perform or teach parents to perform that are riddled with exam traps. Let's start with bathing.
Historically, if you look back a few decades, babies were whisked away from the mother and scrubbed squeaky clean under a faucet within an hour of birth to remove all the blood and fluid.
Right.
But evidence-based practice has drastically changed that protocol, and your exams will absolutely reflect this new standard.
The new priority action is to delay the first bath for 24 hours if possible, or at an absolute minimum, wait at least 6 hours. But I can imagine a new nurse, or even a mother, pushing back on this. You have a baby covered in maternal blood, amniotic fluid, and white goo. It's messy. Why are we forcing moms to do skin-to-skin with an unwashed baby?
It is a totally valid practical question, but we go right back to our lethal triad. If you strip a newborn naked and bathe them in water immediately after birth, you are inducing massive, catastrophic heat loss through evaporation.
Ah, right.
That cold stress triggers the brown fat metabolism, which rapidly causes hypoglycemia and hypoxia. You are prioritizing aesthetics over physiological stability.
And what about that white goo, the vernix?
The vernix caseosa. It looks like cream cheese, but it is actually a complex, magical biological substance. It is composed of sebum and shed skin cells, and it is highly moisturizing and packed with antimicrobial peptides.
So you don't scrub it off?
No, leaving it intact on the skin acts as a natural barrier against hospital pathogens. You rub it into the skin, you don't wash it off.
Okay, so when we finally do give the bath at the 24-hour mark, the water temperature must be lukewarm. The discharge teaching says the home water heater should be set below 120 degrees Fahrenheit to prevent accidental scalding. And crucially, parents should only give sponge baths until the umbilical cord stump falls off.
Which brings us to our next highly testable procedure, umbilical cord care.
Let's talk about the cord. When it is cut, you leave a little stump clamped on the belly.
Yes, and that umbilical stump is essentially dying, necrotic tissue that needs to dry up, shrivel, and eventually detach. But remember, the blood vessels inside that stump connect directly to the infant's systemic bloodstream. So meticulous infection control is paramount.
But the priority nursing action here surprises a lot of people. The text says to keep the stump clean and dry using only plain warm water. It explicitly says, no alcohol needed.
This is a textbook example of old medical practice versus current evidence-based practice. For decades, nurses instructed parents to clean the base of the cord with rubbing alcohol swabs at every diaper change to prevent infection.
Which seems logical, right? I mean, alcohol kills bacteria.
It does kill bacteria, but that's actually the problem. Research discovered that alcohol aggressively kills off the normal, healthy commensal skin flora that actually helps the cord dry out and separate.
Oh, wow.
By constantly sterilizing it with alcohol, we were actively prolonging the amount of time the dying stump stayed attached to the baby. Now, the gold standard of care is simply dry care. If it gets soiled with urine or stool, wash it gently with plain water and let it air dry.
You also need to teach parents to fold the front of the diaper down below the stump.
Right, to prevent a wet, urine-soaked diaper from constantly resting against the drying tissue, and to prevent mechanical friction from the rigid edge of the diaper rubbing and irritating the base.
The expected timeline for the cord falling off is 1 to 3 weeks. But what are the concerning red flags that parents need to report to a pediatrician immediately?
You are monitoring for omphalitis, which is a life-threatening systemic infection of the umbilicus. Parents need to report pronounced redness of the skin spreading outward around the base of the cord, the infant screaming in pain when the skin next to it is lightly touched, and a foul-smelling, purulent yellow discharge.
Okay.
Also, they need to report if the cord simply hasn't fallen off after 3 weeks, as that delayed separation could indicate a rare underlying immune system disorder.
Our very last procedure to cover is circumcision care. This is a massive source of anxiety for parents, and instructors know this, so they test your ability to provide clear, anticipatory guidance. How do you differentiate normal healing from an infection?
Right.
The text outlines 2 main types of circumcision techniques: the use of a clamp like the Mogen or Gomco clamp, and the use of a plastic bell-shaped device called a plastibell.
For the exam, you need to firmly differentiate the nursing care for a clamp procedure versus the plastic bell. They are entirely different. If the physician used a metal clamp to surgically remove the foreskin, there is a raw, exposed surgical wound on the glands. The priority nursing action is to apply a thick layer of petroleum jelly or a piece of gauze heavily coated in petroleum jelly to the tip of the penis with every single diaper change.
This is purely a mechanical barrier, right, to prevent it from sticking to the diaper.
Exactly. If that raw, sticky wound bed adheres to the dry fabric of the diaper, the simple act of pulling the diaper off will rip away the newly forming granulation tissue, causing severe pain and fresh bleeding.
But the rules change for the plastic bell.
Entirely. If the provider used the plastic bell device, the plastibell, they essentially tie a suture around the foreskin over a plastic ring, cutting off the blood supply. The plastic ring stays attached to the penis to protect the glands while it heals. You do not apply petroleum jelly to a plastibell.
Why not?
Because the petroleum lubricant can cause the protective plastic ring to slide right off prematurely. The ring will naturally detach and fall off on its own in about 3 to 7 days as the tissue necroses.
Okay, that's a brilliant distinction. Now, regarding the healing process, what does it look like while it's healing, and what is the trap?
As the mucosal tissue of the glands heals over the first 24 to 48 hours, a yellowish, sticky film or exudate will form over the tip of the penis. This is normal granulation tissue.
But to a terrified new parent, a yellow sticky film looks exactly like pus.
Precisely. It looks exactly like an infection. What's fascinating here is how the expected yellow exudate of healing looks so much like an infection to a terrified new parent. That's why anticipatory discharge teaching is a clinical priority.
You have to warn them.
You must proactively tell them, tomorrow you are going to see a yellowish film. Do not panic. Do not try to wash it off. Do not pick at it. It is the body's natural scab. If you wipe it away, you will cause bleeding.
Then what does an actual infection look like? How do they know when to call the doctor?
Concerning signs of infection are if that yellow film turns into hard-crusted, painful sores, excessive swelling of the entire shaft, deep redness that persists or worsens beyond a week, or a foul necrotic odor.
What about bleeding? It's a surgical site, so a little blood is expected, right?
A few dime-sized drops of blood on the diaper are entirely normal. But if there is active, bright red bleeding larger than a 2-inch diameter circle on the diaper, that is an active hemorrhage that needs to be reported and evaluated immediately.
And there's one final critical safety check post-circumcision mentioned in the modules.
Yes. The infant must urinate within 12 hours of the procedure. The surgical trauma causes localized edema. If that swelling gets severe enough, it can mechanically compress the urethra, causing complete urinary retention.
Oh, wow.
The bladder will fill, back up into the kidneys, and cause severe damage. If they haven't had a wet diaper in 12 hours post-op, you have a urological emergency.
Wow. Okay. We have covered an absolutely staggering amount of ground today. From the intricate psychology of the mother's mental state to the devastating potential of postpartum hemorrhage, all the way down to the cellular metabolism of a newborn's brown fat. It is time for our final review.
Let's do it.
We like to boil everything down to its absolute essence. If you, the listener, only remember 5 things from this entire exhaustive deep dive, what are they?
Number 1, maternal red flags. Do not ignore a headache. A severe headache accompanied by visual floaters points to postpartum preeclampsia and impending seizure. And bleeding soaking a perineal pad in less than 1 hour points to uterine atony and hemorrhage. Both require immediate clinical action.
Okay, number 2.
Number 2, the lactation trap. Non-lactating clients must avoid all breast stimulation to chemically suppress their milk production. No warm water in the shower hitting the chest, no pumping, no expressing milk. Tell them to use ice packs and wear a tight supportive bra 24/7.
Number 3.
Number 3, newborn heat loss. Memorize the 4 physical mechanisms: evaporation by drying the wet baby, conduction by warming the cold scales, convection by blocking the AC drafts, and radiation by keeping them away from cold windows. Protect their brown fat at all costs.
Awesome. Number 4.
Number 4, breast milk storage. Remember the rule of 4s and 6s. 4 hours at room temp, 4 days in the fridge, 6 months in the freezer. And discard any unfinished milk from a bottle after 2 hours to prevent bacterial incubation.
And finally, number 5.
Number 5, healing versus infection. A sticky yellow exudate on a healing circumcision is a sign of normal granulation. Leave it alone. But a foul-smelling yellow discharge from the base of the umbilical cord is a sign of a dangerous infection called omphalitis.
That is a phenomenal high-yield top 5.
Yeah.
And as always, we want to leave you with a final provocative thought to take with you into your exams and your clinical practice.
Think about how every single clinical intervention we have discussed today connects to another in a massive physiological web. If a newborn gets cold via convection or evaporation, they are biologically forced to burn their brown fat to stay alive.
Right.
Burning that fat takes immense, unsustainable amounts of oxygen and glucose. Suddenly, you don't just have a physically cold baby, you have a hypoxic, hypoglycemic, acidotic baby who is now too weak to feed effectively, which means they can't replenish the glucose they just lost.
It's all connected.
It is. As a future nurse, when you put a warm knit hat on a newborn's head, or when you confidently advocate to a physician to delay a bath for 24 hours, you are not just checking off a mundane task on a flow sheet. You are literally preserving their cellular energy. You are protecting their brain tissue from hypoxia. You are saving their life. Keep that standard of care, that high-level, interconnected physiological understanding in your mind every time you sit down for an exam or step onto the unit, and you will do great.
This deep dive is designed as a tool for your success. We know exactly how hard you're working to master this material, and we are so incredibly glad you let us be a part of your study session today. Keep digging into the intricate why behind the simple what, trust your clinical judgment, and we will see you on the next one.